Now, I'm very pleased that we are now going to move on to the first of our keynote talks, and so I'm very happy to invite to the stage Professor Katherine Payne, and you have her full biography, I think, in your paper, so I won't read it all out because it's long and it's distinguished, but Katherine has a chair in health economics at the University of Manchester, and her particular research interests are on the economics of precision medicine, and particularly the evaluation and valuation of genomic technologies and services. So this is a really important topic for us, of course, and Katherine is now going to talk about personalised medicine and health economics, and specifically her talk is the art of defining benefit for individuals and society. And hopefully we will have time for a few questions after this talk, so if you have anything, store it up and we will ask Katherine at the end. So.
Thank you very much. Thank you very much for inviting me to speak today. It's a pleasure to be in Berlin, a lovely city. So yes, I was given this title, so I've adapted it to suit my own needs. So if you see at the end whether you think I've actually addressed the topic of the title, you can rate me on that. I've actually also taken the liberty of using my own definition of personalised medicine. I understand and do use the European Commission definition, but we found within my own research group, which comprises health economists working with different people across different disciplines, that this definition actually suits us better because it reflects the breadth of the concept. So we feel that personalised medicine is underpinned by the premise that it's feasible to identify known heterogeneity. So that key word there is the known heterogeneity. And that heterogeneity can be within a disease or a population, and it's important that you then use that information to guide management strategies with the end goal of improving health and well-being. So in some ways, and in theory, this is the perfect solution to the challenge of maximising value for money. But that's the theory. What we need to see if that actually is realised in practice. So then taking that definition into an actionable, practical concept, personalised medicine requires some personalised component. And that component has to be there to enable the selection of either optimal screening strategies, interventions or therapies. So that component can be a single diagnostic test, and more we're seeing development of algorithms combining a number of tests and patient-level characteristics. Now, you can see there that I've taken a very broad interpretation of what I mean by personalised medicine. So I will, in my presentation, show you some examples of personalised screening strategies and personalised medicines. So that again needs some mechanism or tool that we can then use in practice, so a clinician can take that tool and actually use it to provide them with additional information than they would otherwise have. And that's an important concept as well when you start to look at the health economics of personalised medicine, because that information has to provide added value to what they would currently do in terms of selecting treatment strategies. And that mechanism or tool can be informed by a variety of different mechanisms, so you could use genomics, transcriptomics, proteomics, metabolomics. Now, my bottom line is for this talk is that all this is great, and the theory is great, the concept's great. But you need evidence. You need evidence to support the introduction of personalised medicine into clinical practice. And that's where my stance as a health economist for this talk. So, within my title, I had the word benefit. So, first of all, I have to be very clear, what do we mean by benefit and who will realise this benefit? So, what do we mean by benefit? Well, I actually prefer the use of the word value, because benefit is synonymous with this idea of value, and it reflects the worth of doing something. As you'll see in a moment when we start to use methods of economic evaluation, these are really underpinned by the idea that we need to be able to measure the worth of actually providing an intervention to a population of patients. So who will realise this benefit? Many people. And you'll see what I've tried to do within this slide is create a diagrammatic representation of the stages of who will realise this benefit, working up from the individual to the clinician-patient working together as a dyad, through the healthcare system at local, regional or national levels, and then up to society, where you would include patient groups, employers, academics, researchers, regulatory agencies, reimbursement agencies, and also, most importantly, the industries. So my focus today is on the healthcare system. And you'll see that is how we can use methods of economic evaluation to inform resource allocation within a healthcare system. But I'll close my talk as well with an example of how we can use individual preferences to inform resource allocation decisions as well. So I always include this slide with my talk, and this is sort of an aid memoir, really, of what underpins health economics. I'm always quite fascinated to see how many people actually find this funny or not. It's very, I don't know, it's not a brilliant joke, but it gets the point of view across. So if you are making a decision to treat a population of patients with a particular medicine or screening strategy, use a screening strategy in a group of populations. Within a healthcare system, that means you are actually effectively removing that other interventions from another group of patients because we have finite resources. And that is what opportunity cost means, that if you treat one group of patients, you are really not treating another group of patients. There are some important things to remember from opportunity cost. First, we're talking about the population level, not the individual level. Second, when you start to implement opportunity costs, it means you have to make comparisons across different uses of resources. Also, as this slide points out, you have to be very clear what the benefits are. So this guy is friendship's his benefit, although he doesn't realise it. So how do we then move from opportunity cost as a concept into actually trying to know the value of personalised medicine? I find this very simple slide incredibly useful every single day in my practice as an academic, because it actually makes you really think about what is the intervention that you're trying to evaluate. So you have some idea of personalised medicine with some technology that needs to be developed. So that might be the development of next generation sequencing, for example. That is not good enough to get personalised medicine into practice. You need to then move from that next generation sequencing technology into some form of diagnostic that you can actually use to inform practice. And then that again is not enough, because you have to move from that diagnostic strategy into an actual model of service delivery that will get that strategy to the patient at the right time and at the right place. So how can we use economic evaluation? So the first two boxes on this slide can be readily evaluated from the evaluation component of economics. And then when you get into the stage of actually trying to formalise services, that's when I suggest you need to move maybe to actually taking the collective view from patients and members of the public by doing a valuation exercise to understand what they want out of a model of service delivery. So I have got some applied examples later on in my talk where we have some evaluations of actual interventions in personalised medicine, and I'm also going to show you a valuation exercise that we've completed as well. But before I do that, I want to again just orientate your mind into what we do when we actually conduct an economic evaluation. So again, recognising we have opportunity cost, you have to start with being very clear about the process of healthcare that you're trying to evaluate. So here's a very simple example of comparing medicine A and medicine B. You'll see in my applied examples later, when you actually start to describe some of the processes of healthcare, for example, a risk-based national screening programme for breast cancer, that process as healthcare can actually get more complex when you actually try to describe it. So this is what you're trying to evaluate, and you have some inputs that feed into that. So those inputs will comprise the costs of your intervention, so they will be made up of the resources used and the unit cost of each of those resources used. And then ideally you want to get something out of that. This is the reason for being for healthcare systems, so you want to get some outputs. And from an economics point of view, these outputs or consequences can be measured in terms of clinical effectiveness. So you get your cost effectiveness analysis. You can measure it in the quality adjusted life year. So you get your cost utility analysis. Or you can measure it using willingness to pay. So you get your cost benefit analysis. The important thing to point out at this stage as well is that the inputs and outputs of this evaluation are very much driven by the study perspective that you take. So for the National Institute for Health and Care Excellence in the UK, assumes the perspective of the healthcare system. So that means you only include the costs to the healthcare system. Now, in other countries such as the Netherlands, they take a broader perspective and say you should include societal costs. So within that sort of framework, you would include the costs to employers and employment in society. So if we need to measure clinical effectiveness for personalised medicine, what does that mean? It means that we need to be able to pull together end-to-end evidence. And that means you have to be able to close that line from the start to finish so you understand what the clinical effectiveness is for each of these stages. So the first element might be using a technology like next generation sequencing to create your test or algorithm. How well does your technology work in that context to produce the algorithm? That's one element of effect. The next is when you've got your test or algorithm, how accurate is it? And what predictive value does it have? Then that has to actually have some effect on a treatment or a management decision. And then that treatment or management decision has to have an effect on the patient population. Now, in practice, it's actually very hard to design one study to actually get clinical effectiveness for all those elements. So what we as health economists end up trying to do is piece together evidence from different data sources to try and understand that end-to-end evidence. And indeed, if you speak to anyone who works within the NICE Diagnostics Assessment Programme for NICE, they will say this is their sort of fundamental challenge, how you get this end-to-end evidence. So, and then this is just another sort of aid memoir, and again linking back to the UK perspective, but this really underpins how we turn our clinical effect into a measure of health status. So we use something called the EQ5D, an awful acronym. It stands for Euroqual, 5 domains, mobility, self-care, usual activities, pain and discomfort, anxiety and depression. And this really is the fundamental toolkit that we use and is recommended by NICE to understand the impact of healthcare interventions on patients. So if you were trying to introduce a personalised medicine into practice, you would get your patient population to fill in that questionnaire at baseline and at then some point at follow-up and see whether you've managed to create some improvement in health status. So you have to move from that domain level questionnaire into something that we can then use within our evaluation. We need to put it on a number line. Our number line is called utility, where 0 represents the state of death and 1 is when you're in top perfect health. And so where you fit along that line is how we measure what your health status is, and we've generated that from a measure that the patients actually completed themselves. Now, a few observations. It's very simple, it's very quick to complete, but it only captures the elements that you see described in terms of health, so it has some limitations. So how do we use that? We move from that to our famous QALY. So our QALY says, okay, we all have a number of years of life left, but we're not going to be at perfect health for all those years of life. And so what we can do is we can represent through a line of health status that says, okay, at a particular state of length of life, you're in this particular health status, and we capture that change over time. So you generate your QALYs by calculating the area under the curve. Again, a simple construct, but in practice, it's very useful to use. But this is a very useful white paper produced by the Office of Health Economics in conjunction with ICPerMed, and it actually started to say, okay, if we're thinking about personalised medicine, what we've got there is actually a test element combined with a treatment element. And this, historically, we've seen very good examples of where the QALY has been very good at capturing the treatment element in terms of health gain. It's not so good in capturing the value of the diagnostic component. So this really was what this report was about, and really explained how if you're looking at HTA of medicines and devices, in some instances they may actually overlook or even undervalue important elements of value, and in particular the diagnostic component. Now this is one particular area of research interest for myself. So how do we capture this value of knowing? So again, going back to my simple line diagram here, when you're generally using a QALY within an economic evaluation, the impact on QALYs that you're seeing is all tied in with the effectiveness of the treatment. You're not really picking up any of the impact on QALYs for all the other contributions of that linear strategy. So what do we do about that? So I'm working with a PhD student, Martin Eden, who's starting now to publish some of his work. And what he started to do is think about he's looking at a genomic-based diagnosis specifically, but he's trying to say, okay, if we're trying to capture this value of the diagnostic component, how do we do that? So the first thing is really to understand what you're trying to value here. So he's created this taxonomy of non-health value. And he's done this by going out to the literature and assimilating all published qualitative pieces of work that have asked people using genomic tests or genetic counsellors what they think is of value to them when they actually approach these services. So he's created these three concepts, so informed decision-making, benefit to others, and the intrinsic value of knowing in itself. And he's actually taken examples of the published literature to actually illustrate what we actually mean by each of these different concepts. So informed decision-making is really captured by McAllister when they said it's about making important life decisions in an informed way. The benefit to others, so if you have a genomic-based diagnostic test, it's about the test being perhaps more important for the children than the individual who had the test. And then the intrinsic value of knowing is really about giving insight or answers to this persistent question of why do I have these symptoms? What is this disease that I have? So we need to take that qualitative element and turn it into something that we can measure. I'm a health economist, so I need to be able to measure things. So one conceptual approach that we've been trying to do that is to implement this idea called capability, which was introduced by a philosopher called Amartya Sen. And Sen was very good. He sat on the fence. He didn't really say what he meant by capability and just let everybody else try and work it out from themselves. So there's been a lot of work now trying to think about, well, what do we mean by capability? In essence, rather than health status, capability is about your ability to do something. So health status measures how you are now, whereas capability is, am I able to do this? Am I able to function? And you'll see the ICPerMed adult there that's been designed as a measure of capability. That is really about physical and functional status. The papers on the left there really have started to think about capability in another way in terms of your capability to make an informed decision. Now, the reason it's important to actually underpin everything by things that Sen said is that it gives you a theoretical structure to actually designing your patient-reported outcome measure, which is what your ICPerMed might be. So this is one way that we're trying to think about how you might move beyond health and capture diagnostic value over and above the value of a treatment strategy. The other way we've been doing this is to move into the domain of cost-benefit analysis. So here within this pilot study, we actually designed a survey where we got people to try and attach a monetary value to using genetic testing for an inherited eye disease, retinitis pigmentosa. So the value here was, first of all, attached to sort of genetic counselling. Do I get a light? Oh, no, I don't get a light. I'll just go backwards. So the GC stands for genetic counselling, and the GC and T stands for genetic counselling and testing. So when we ask people to attach a value, you can see here by looking at the shape of the histogram that people actually did attach more value when you introduced testing. So they actually were prepared to put their money where their mouth is and say, yes, I actually value genetic testing over and above genetic counselling. But cost-benefit analysis sits within a different paradigm to cost-effectiveness analysis. Cost-benefit analysis fits within a paradigm of something called welfareism, which means that you value consequences using willingness to pay, and your decision rule is you say, okay, let's choose an intervention where the benefit outweighs the cost. It's not the same theoretical underpinning as cost-effectiveness analysis, which is what we use within the UK setting at the moment. That is underpinned by a concept called extra welfareism, and that actually says you can actually take a pragmatic approach. So if you are trying to think about how to spend money within a healthcare system, you think about what that healthcare system wants. It wants to maximise health, so you maximise quality-adjusted life years. Your decision rule there, you can see the famous cost per quality there. The importance of this slide here is that cost-benefit is not the same as cost-effectiveness. And if you generate evidence for a decision-making using a cost-benefit analysis, you can't directly compare it to your cost-effectiveness analysis. So that opens up another conundrum, if you like, for how you start to produce evidence of value so it is useful for decision-making. You've got to be very clear what your decision-maker wants. Are they a welfareist person or are they an extra welfareist person? So I've just got 10 minutes left just to go through my case studies. I won't use that whole time, so there'll be a few moments for questions. So, case study 1. This is a very old example, but it's still a very useful example. So, TPMT is used to inform the prescription of azathioprine for people with autoimmune diseases. What TPMT does, it says, it groups people very simplistically into one of 3 categories. 1, you should never have azathioprine. It's not good for you. It will kill you. 1, you can have azathioprine at any dose you like, it will be safe. And then you have the one in the middle where it says, yes, you can still have azathioprine, but you should use it cautiously. That is a very lay view of what TPMT does. So we conducted a trial-based analysis and said, okay, what is the value of using TPMT genotyping for azathioprine? And this is what we got. So this looks like someone sneezed on the page. They haven't. So it's actually a representation of comparing TPMT with current practice. So on your x-axis, you have the difference in QALYs, and on your y-axis, you have the difference in costs. So you can see most of those spots there appear down in that southwest quadrant. That means that TPMT turned out to be cheaper, but also less effective. You had negative QALYs. Why did that happen? It wasn't because the TPMT test wasn't very good. It was because the clinicians in the trial didn't actually use the test results as was intended. So they did not change their prescribing behaviour. So that's why I always use this slide, because it's a very good illustration of whilst the test might be very accurate and have good predictive value, it doesn't matter if your clinicians don't actually follow the test results. Not a dig at clinicians. Case study 2 was looking at a stratified national breast screening program using risk estimation and Volpara breast density. So this was a model-based cost-effectiveness analysis, and it was built around this study funded by the Framework 7 called Assure. And the idea is that you can use a risk estimation approach to actually classify your risk into women into low risk, increased risk and high risk, and then following on from that, you look at breast density to actually see if they again can be further categorised. So we've published this result. This is an early model-based economic evaluation. That means we use the data that we had available at the time. So these results are indicative, they're not definitive. And you can see there, though, that if you look at using a risk stratified screening program, it's looking like it might be a good use of healthcare resources in terms of the cost per QALY. Whereas if you start introducing masking approaches, it's actually not looking so promising. So my last example is where we start to look at evaluation study. So here we really are moving into the realm of sort of hypothetical interventions. So I've been working with a group called Matura, which is funded by the MRC, Stratified Medicine Consortium, funding program, sorry, a consortia funded by the funding program MRC. And what we've done here is working with the clinicians is create this idea of a biologic calculator. So this is a calculator that you could use in clinical practice to target the use of a biologic therapy for people with RA. It doesn't actually exist at all. We've made it up. And we've said, okay, if we present this to a group of patients and members of the public, what do they think about it? What are their views about this particular calculator? So to find out what their views are, we do something called a discrete choice experiment. And down the left-hand side, you have the important attributes of the calculator. So does it cause a delay to treatment? What's its positive predictive value? What's its negative predictive value? What's the risk of infection if you give a biologic? And what might be the cost saving to the NHS if you manage to actually use that biologic more effectively? So you pose a number of these scenarios to patients and you estimate the results using regression-based methods. That in itself is interesting, but what can we do with that? So this is when we turn it into a tool where you can actually go and predict uptake. So what you see there is this is fed by an analysis of a sample of patients who've completed your DCE. And you can see you've got the conventional approach on the left-hand side and you've got your prescribing algorithm there. And if you look at how we then use their preferences, you can see using the numbers of positive predictive value and negative predictive value you see on the slide, that 77% of your population would actually want to use that prescribing algorithm. So that's giving you some indication of how negative predictive value and positive predictive value might influence uptake. So my last slide. So what we've been talking about here is about informing resource allocation at a health system level, so the population level, with the use of economic evaluation. We need end-to-end evidence, and so model-based economic evaluation is often the way to go to actually try and assimilate the evidence that you need. Now, providing data on incremental costs and QALYs, I believe is necessary, but I don't think it's sufficient, because you may not see the value of the diagnostic captured within some of the simple analyses that we've seen so far. And so you can supplement some of those, the QALY data with maybe using capability as a concept, but also valuation studies to understand the collective view of individuals within society about how good your algorithm or test has to be to change clinical practice. So I'll end with sort of a picture of my team that I work with in Manchester, and they've all contributed with the different elements of the examples I've given you. So thank you very much.
Stay there, Katherine. So that's very interesting indeed. Do we have some questions? I think we have a little bit of time for some questions from the audience. Don't be shy. We've been doing all the talking up here, so you can, throw it open to the floor. Yes, right here. Sorry, there's microphones there, so just say who you are. Thank you.
Susan Kentner from the German Cancer Research Center in Heidelberg. I'm going to try and formulate my question because I'm not sure I understand my question myself. But what I'm interested in is your work seems to provide the knowledge base that decision makers need in order to make decisions about how to allocate resources. But do you also analyze the processes by which these resources are actually, in reality, allocated? As an example, I seem to recall an example some years ago in the UK about a controversy involving a very expensive cancer medicine for breast cancer. And there was some discussion about whether to reimburse that. medicine. And I'm wondering, I mean, that's obviously an important question. I mean, if medicines are available and they have a known benefit, but then they are not reimbursed because of the social value system, meaning the government decides whether to improve the health outcomes for a very small group of people or to use the same resources to improve possibly the health outcomes for another group of people, a larger group of people. And I'm just wondering if you study the processes of prioritization.
Okay, that's a huge question. I'll try and break it down very quick and give a very quick answer. So you've got different components to this. The first thing is you've got what I've just presented, which is, as you said, this is the knowledge you need. This is the knowledge about economic evaluation, so you're getting this much benefit, but it's costing you this much. You then need to put that to some decision-making committee or process. So that's when you get NICE, who actually look at that evidence and say, on balance, we believe that evidence. That's important. When you're saying it's that medicine had benefit, there would have been inherent uncertainty around those measures of benefit. So it's the uncertainty that often drives the decision. I didn't have time to explain that. The other bit is about how you then move from saying, okay, we think this is a good use of resources, to getting it into clinical practice. That's when you start to maybe need to address things like capacity constraints, which becomes very important in personalised medicine. So you might need a particular test. Your healthcare system might not have either the skills or the number of labs to actually provide that test. You can also use economic methods to actually look at those capacity constraints as well. So there's different steps in the system that you have to address.
Okay, I think I'll come to you in a minute, but I think there's a lady down here behind. Was there somebody behind? No.
Disappeared. Yeah.
Disappeared. Okay, well, this gentleman here, right here in the second row. I think there's a microphone coming your way.
Thank you. My name is João Lavinha. I work for the National Institute of Health in Lisbon, Portugal. I appreciated very much your proposal of definition of precision medicine, which is nice, and I took a note. The ability, the feasibility of identifying known heterogeneities within a disease or population. But then you only referred to omics tools. And my question is, would these constructs and methods of economic analysis apply to non-biological determinants of health?
Yeah, absolutely. And so, if you looked at that biologic calculator, you could see there were some patient-level characteristics in there as well. So that's one element that you can introduce. I just threw the omics in there just as an example. The other thing is interesting to think about is whether you mean personalisation by some biological mechanism or personalisation by preferences. And I've also thought about that quite carefully. So there is another way of where you actually think you need to disentangle the preference element from the biological element. So the answer is yes. Okay.
Okay, any more questions? Yes, right here in the middle.
Thanks very much. My name is Louise Binder, and I'm from Canada, Save Your Skin Foundation. So you defined value as the worth of doing something. I'm wondering if you look at all at the value-based healthcare approach that Porter and Teisberg have put forward, which is that basically value is only in the eye of the patient, and that all the analyses of whether something is worth doing or not should be through patient-reported outcome measurements, and those measurements are not patient-reported healthcare.
Yeah, okay, so they are. So they are.
Well, they aren't, though. I mean, we've talked to ICHOM about this very recently, and even they confess that the measurements that they've created, although they had some patient engagement in developing them, were not really patient-created. They may be citizen-created, but not patient-created. It's quite a different thing.
Okay, so we're getting into the realm of what is a patient-reported outcome measure. I think again, what I did not have time to talk about is the need to be able to compare across interventions. So while you might have disease-specific, and I've been involved in developing disease-specific patient-reported outcome measures, they are useful, but then you have to then be able to say, okay, we've got to compare between people who have RA and people who have depression. If you want to work within resource allocation within a healthcare system. So you're shaking your head. So it's just, if you work with NICE, you might one day see a technology appraisal for people with breast cancer, and the next day you might see something for biologics for people with RA. If, as a decision maker, you want to be able to say, okay, this is of equal worth to this person, from NICE's point of view, you need to have some generic measurement scale. Whether that's right or wrong, there's different paradigms. So.
Okay, we'll take one more, I think, over here on this side of the room. So it's microphone coming your way.
Piotr Fiedor, Warsaw Medical University. Thank you for very elegant presentation. So I have a simple question for you. So could you share with us information about the case one? Case one, you said about azathioprine research and cost effectiveness. So my question is, if you use for autoimmune disease or chronic disease, these are very cheap medicinal products. So do you have an outcome, long-term outcome for the patients, and you observe, for example, skin cancer or cancer for them, and then it's cost after that?
So yes, they're cheap medicines, but they are also very poisonous medicines. So azathioprine is not a nice medicine to take if you're a patient. So the value in using TPMT is avoiding the experience of having severe, profound neutropenia, which is not nice if you're a patient, but also the cost to the healthcare system of trying to manage it. So yes, you might say they are cheap, but also a lot of people use them. So that was one reason why it's important to have an economic viewpoint on TPMT. You can take that same framework and apply that to more expensive medicines. For example, Herceptin, you could take that same framework and look at the relative cost effectiveness in that way as well. I hope I've captured your question there, I think. Yeah. Okay, thanks.
Okay, so Katherine, thank you very much indeed. That was a wonderful talk. Thank you.
Thank you.